ACCEL continues with a discussion Nanette Wenger had with Dr. Michael Ho, Associate Professor of Medicine at the University of Colorado in Denver, on multifaceted intervention to improve medication adherence and secondary prevention measures after ACS hospital discharge.
We all know that adherence to medications after an acute coronary syndrome is a challenge. Tell me something about the components of this adherence program that you've designed.
Thank you, Dr. Wenger. There were 4 components to the intervention. The first component was medication reconciliation and tailoring. The second component was patient education. The third component was collaborative care between the study pharmacist and the patient's primary care provider or cardiologist. And the fourth component was voice messaging. There were 2 types of voice messaging. The first one was educational, which focused on the importance of adherence to medications. The second component was medication refill reminder phone calls that would remind the patients to refill their medications when it was time.
So tell me then the additional personnel to what might be done conventionally that were involved in the implementation of this study.
So the main additional personnel was the pharmacist who delivered the educational messages, spoke to the patients if they had any problems, and did the medication reconciliation 7 to 10 days after hospital discharge.
Now we want to know the design of your study. Tell us something about the patients and precisely what happened.
Yeah, so this was a study that was conducted at 4 VA medical centers, and patients were randomized in a 1-to-1 fashion. The average age of the patients was about 64. They had a number of comorbid conditions. About 45% had diabetes and about 60% had prior coronary disease. And in terms of presentation of ACS, about almost 60% presented with unstable angina and about 30% presented with a non-ST elevation MI.
How many patients?
So we had 253 patients.
And they were followed for how long?
They were followed for 12 months after hospital discharge.
What happened as a result of this intervention?
Our primary outcome was the proportion of patients who were adherent to their medications based on pharmacy refill data. A greater proportion of the intervention patients were adherent at 12 months as compared to usual care. It was 89% versus 74%. And the findings were consistent when we looked at the individual classes of medications. So for statins, ACE-ARBs, and clopidogrel, but there was no difference in the proportion of patients who were adherent to beta blockers.
Then what about some of the laboratory or other measures? What about blood pressure? What about LDL cholesterol?
Unfortunately, there was no difference in the proportion of patients who achieved their blood pressure or LDL targets between intervention and usual care. There was also a similar number of clinical hard endpoints in terms of rehospitalization for MI, revascularization, and death.
And obviously, this is an addition of time and people to what is usually done in the system. And one of the questions will be, certainly there's a substantial difference in adherence that you've shown in this trial. What was the cost, and how did you calculate costs?
We estimated that the total cost of the intervention was $360. This was based on direct observation of the time required for personnel to deliver the intervention. So $360 over a 12-month period.
I know this was not an official part of the study, but was there any conversation among you or your research coordinator or the patients as to whether they liked this approach? Was there anything that you could tell on a formal or an informal basis?
We also did some qualitative interviews following the study to try to get a sense of what components of the intervention seemed to work better. And I think one of the main messages that the patients liked about the intervention was the engagement with the healthcare system. It wasn't they left the hospital and that was it. They had a pharmacist who would contact them if they had problems. And they also had these telephone reminders that would kind of help facilitate them getting their medication. So I think the whole package helped to engage them in their health care.
Well, certainly one study is not going to change a VA medical system, but what are your next steps to seeing what you can do based on the results of this study?
Yeah, so I think one of the initial studies that we'll be doing is looking at the outcomes over a longer period of time. The duration of follow-up was only 12 months, so it's relatively short. The other area of investigation is to test this intervention in a greater number of hospitals to see if we can impact not only adherence, but also the other clinical outcomes in terms of blood pressure, LDL control, as well as the hard clinical endpoints.
Well, this is really a very exciting outcome to the study because a fairly simple intervention, not personnel intensive and relatively inexpensive, showing you a substantial improvement in adherence. This is a very exciting outcome with promise. Thank you.
Thank you.